First presenter is going to be Brian Weeman. Right, and she's going to be talking about tracheostomy in ventilator-dependent COVID-19 patients, impact on analgesia and sedative requirements during a national shortage.
Thank you, Dr. Fonson. Hi, everyone. Good afternoon. My name is Dr. Weeman. I'm a PGY3 at the University of New Mexico, and luckily I get to shave off a little bit of time because Dr. Fonson already read out the name of my presentation. I have no financial relationships to disclose. So, as my introduction, current literature shows that tracheostomy decreases the time that patients require invasive mechanical ventilation support, ICU length of stay, long-term mortality, and the amount of sedation that patients require. This last point takes on increased importance due to the ongoing shortages of critical care medications secondary to COVID-19. We hypothesize that analgesia and sedative requirements decrease following tracheostomy in ventilated patients with COVID-19. We performed a retrospective chart review with the inclusion criteria as follows. Patients having COVID-19 as their primary diagnosis, undergoing tracheostomy, and not on ECMO. From this cohort, we retained 50 patients for analysis. For these 50 patients, we did a chart review and looked at these medications as listed here in 4 main categories and summed up our total oral morphine equivalents, total lorazepam equivalents, standard dose rate of Precedex and propofol. We then compared these dosages on days T-1 and T+2, where T is our day of tracheostomy. We compared these via a student's paired t-test with a p-value set at 0.05. Within this cohort, we saw that 46 patients required opioids before and after their tracheostomy, 8 benzodiazepines, 15 a Precedex infusion, and 17 a propofol infusion. All 4 classes of medications had a mean decrease in dosage after tracheostomy that was statistically significant. Current literature, it is thought that the benefits of tracheostomy include physiologic changes to a patient's airway, facilitation of oral and bronchopulmonary care, and decreased patient anxiety. So in conclusion, we urge consideration of early tracheostomy for COVID-19 patients requiring ventilation to reduce patient discomfort and to preserve sedative and analgesic medications during an ongoing national shortage as shown here.
There you go.
Questions? So I have a question. So it's kind of expected for the anxiolytics to go up, to the usage of anxiolytics to go up. Why the pain medicine going up too?
Yeah, so I wonder if it's not so much that the actual pain that a patient experiences decreases following tracheostomy, but rather that we as providers conflate pain and anxiety and sometimes use pain medications as anxiolytics. That to me makes more sense and seems more borne out in current data rather than tracheostomy versus endotracheal tube as less truly painful.
So does this mean we're advocating for early tracheostomy for these patients?
Yes.
Just a quick question, Jerkovich from Sacramento. How many were done in the operating room? How many were done at bedside? And for those who were done at bedside, was it full PAPRs during this time? I mean, did you use full protective equipment? I guess I'm just saying, is it really worth it? In the middle of a pandemic, the most infectious disease known to mankind, and you don't really need a trach. I mean, it's not necessary. Just that question of why.
Yeah, so these were all done at bedside rather than in the operating room, and full PPE was worn by all the professionals involved. And of note, we did have a very sparse team doing these. There were essentially 2 attendings who were doing all of those tracheostomies. Fellows and residents were asked not to participate in these cases for that exact reason. We didn't want to confer undue risk to our providers. So I agree, it's certainly high risk. And that's why many of the other protocols that I looked at from other institutions coming up with this research truly were in a line with your philosophy that it's not strictly necessary. I would argue that we still urge this earlier consideration since we do have these ongoing medication shortages and an ongoing pandemic.
All right.
Great.
Thank you. The next presenter is Dr. Jennifer Yonkis from the Mayo Clinic, Rochester.
Pancreatic fistula is a major source of morbidity in patients undergoing Whipple. In 2014, we developed and published a surgeon-driven pathway aimed at reducing this morbidity. This pathway utilized the fistula risk score to determine use of drains, feeding tubes, and octreotide. The initial year of this pathway led to a cost saving of $1.1 million, driven mostly by reduction in hospital length of stay, readmission, and need for interventional procedures. The present study aims to answer the question, is this pathway sustainable and applicable over time? 194 patients undergoing Whipple between 2018 and 2020 were compared to the initial cohort of patients on the pathway. The fistula risk score, which includes intraoperative blood loss, pancreas texture, indication, meaning diagnosis at time of Whipple, as well as duct size, patient demographics, and rate of pancreatic fistula were compared, as were cost-saving metrics of hospital length of stay and readmission, as well as need for interventional procedures. Patients in our recent cohort were more likely to undergo Whipple for cancer diagnosis. There was no difference in grade BC pancreatic fistula. The recent cohort was more likely to undergo neoadjuvant therapy and vascular reconstruction. The fistula risk score was able to predict fistula even in patients after undergoing neoadjuvant therapy. There was sustained reduction in the cost-saving metrics of length of stay as well as interventional procedure. However, we saw nearly a doubling in readmission rate in the modern cohort. In conclusion, we're performing an increased percent of Whipples for cancer indications, and these are increasingly complex operations. Despite this, the surgeon-driven pathway led to a sustained reduction in length of stay and interventional procedures. However, we did see a significant increase in readmission rate. There was no difference in the rate of pancreatic fistula, and there was sustained ability to predict fistula in patients even in the area of neoadjuvant therapy.
Thank you. I'll open it up for questions.
Enjoyed the presentation.
Thank you.
I always think that when you can decrease variation and increase consistency, you're going to see improvement in outcomes. But the biggest variation in pancreatic surgery Whipple procedure is the pancreatic ojejunostomy. So do all your surgeons at the Mayo Clinic, when they do the reconstruction with the pancreatic ojejunostomy, do they use the same technique? If not, then some of this is a little bit, there's an inherent variation there, an inherent bias if they're not all standardized the technique.
Thank you very much for that question. That's a very good point. I believe that there are some differences that are used between the surgeons. I'm not familiar with all of them and their specific techniques, but I bet there is variation, and that would be something very good to look at when we're preparing the manuscript to see if there's differences in these techniques. Thank you.
Terry Larimore, LSU Shreveport. I enjoyed your study, especially the cost savings aspect of it. Could you elaborate further on how you alter the management of patients who have a higher pancreatic fistula risk score? Do you change whether they have drains, how long the drains stay in? Do you use drain fluid amylase levels? Do you use octreotide? How do you alter their care?
Yeah, so that was the design of the pathway. So if you have a higher fistula risk score, you get an increased number of drains. So it's either no drains, one drain, or two drains based on the fistula risk score. And additionally, the use of octreotide is based on a cutoff from the fistula risk score. I'm sorry, did that answer your question? Drain fluid amylase. So biochemical leak is not going to get, to my understanding, treated on the pathway anymore. It's treated separately. So we're really looking at reducing grade BC fistula. And it's
Right.
those intraoperative metrics of blood loss and the duct size and the gland texture.
All right,
Thank you.
So our next presenter is going to be Dr. Karen Gibb from Cook County Hospital.
Good afternoon. My name is Karen Giab. I'm a research fellow from the Department of Trauma and Burn Surgery at Cook County Hospital in Chicago, and I'll be presenting a rather interesting topic on the differences in outcomes between right versus left colonic injuries. It remains unclear whether injuries of the right colon behave differently than those to the left. However, the rates of surgical site infections remain high. This study aims to determine whether outcomes differ between right versus left-sided colonic injuries and abdominal trauma, and to identify risk factors associated with surgical site infections after these injuries. Using the TQIP database, we identified adult patients admitted for abdominal trauma with minor head and chest injuries, who were then stratified by right versus left colonic injury. Injuries to the right colon were often the result of blunt injuries, while the left colon had a larger proportion of penetrating injuries. Injury severity were similar, and the two groups was similar in terms of age, gender, ED parameters, and comorbidities. Unadjusted analysis showed no differences in outcomes between the two groups, with an overall median length of stay of almost 2 weeks, ICU stay of 5 days, 15.6% surgical site infection rate, and 5% mortality. However, unadjusted analysis, left-sided colonic injuries were associated with twice higher likelihood of mortality compared to the right. On multivariate regression, while surgical site infection was not influenced by the injury location, male gender, injury severity, and penetrating mechanism of injury were found to be significant risk factors. Higher incidence of mortality in left-sided colonic injuries may be attributed to associated injuries or management decisions or both. A larger study to determine the risk factors for mortality in left-sided colonic injuries is indicated. Thank you.
Questions? So I have a question. So the left side injuries were mostly penetrating injury,
Correct.
right? So, and the right side were blunt injuries. So clearly there was more contamination on the left side than the right side.
Yes. This is true because the injury pathophysiology is different between both blunt and penetrating mechanism of injury, and with penetrating injuries, there may be a higher risk of fecal contamination, of contamination with foreign material, as well as devitalized areas because of the injury. However, the rates of surgical site infection was not different between right versus left-sided colonic injuries.
Was when you talk about the left side, was the rectum also involved in that
No.
side? Or no?
We looked at right versus left to look at more isolated injuries to the colon.
All right, thank you.
Thank you. And to stay on the hot seat, Dr. Karen Guab from Cook County for the next presentation.
So now I will be presenting regional variations in clinical outcomes after laparoscopic cholecystectomy for acute cholecystitis. This study examined outcomes after laparoscopic cholecystectomy across the different regions in the US based on patient and hospital characteristics. This is a 3-year retrospective review of the NIS database. Differences in the following outcome measures, particularly conversion to open cholecystectomy, bile duct injury, other postoperative complications, and in-hospital mortality were compared. The Midwest had the highest prevalence of obesity and comorbidity burdens. However, the South had more patients in the self-pay or uninsured. Similarly, the South and the Midwest had more patients in the lowest income bracket. And as far as hospital characteristics, there were more rural hospitals in the Midwest and in the South. The Midwest had significantly greater rates of conversion to open procedure. The Midwest and the South had higher rates of paralytic ileus, AKI, and pneumonia. And patients in the South had significantly greater rates of UTI postoperatively. On multivariate regression, adjusting for patient and hospital characteristics, geographic region was not associated with any differences in risks of bile duct injury or mortality. However, the Northeast and Midwest had higher rates of conversion to open procedure compared to the West, and the South had higher rates of complications. Despite higher rates of obesity and comorbidities in the Midwest, the South had higher complication rates driven by UTI, AKI, pneumonia, and paralytic ileus. Further studies are needed to optimize interventions that lower the risk of complications. In conclusion, there was a significant regional disparity in outcomes after laparoscopic cholecystectomies, and the specific targets for quality improvement require further studies. Thank you.
Thank you. Questions?
Well done on both of those. So any idea why that would be? Did you have the opportunity to look at smoking rates, for example? I'm glad to hear that obesity is higher in the Midwest, but yet the complications are not more, because obesity has been shown over and over again to be a risk factor for bile duct injury with acute cholecystitis. So that was good to see that. But what's the reason for the South? People move all over now, so that people are trained all over. So there's nothing inherent to the South. Is it something else that maybe the NIS is not capturing?
Right, so I would like to address the question about smoking. This is actually a variable that we were not able to look at in this study, but we do believe that it is important, and we are happy to explore this further. While we did adjust for patient and hospital characteristics, of course, we were limited by the extent of data that was available with the database that we utilized. One thing that we were not able to look at is physician characteristics or surgeon characteristics, particularly surgeon volume procedure, which we think are important as well. And again, this is something that we're happy to look into even more.
I really think you should present this paper in New York, not in, not here.
Thank you.
I rise to ask you if you've considered other factors like access to care and presenting at a later stage. Some people in disadvantaged parts of the country have decreased access to care and tend to be more reluctant to seek care, and they present at a later stage. So the question that would be, did you look at the severity of, did you have any metrics that looked at the severity of acute cholecystitis that presented in different regions of the country?
Yes. So with regards to the severity of acute cholecystitis, this was something that we were not able to look at due to the database that we utilized. With regards to low access of care, although we do recognize that the Midwest and the South had more patients in the lowest income bracket, and this may affect their outcomes post-operatively, but we were able to account for these factors in our multivariate regression.
All right,
Thank you.
Our next presenter is Clarissa Hoffman from University of Texas Health Center in Houston.
Good afternoon. Prevention of recurrence remains a challenge in laparoscopic hiatal hernia repair. Fundopexy may decrease the rate of recurrence. Our aim was to compare clinical outcomes of toupee versus fundopexy. Fundopexy was performed by placing interrupted stitches between the stomach at the level of the divided short gastric vessels and the left upper abdominal wall. Fundopexy was performed in patients 60 or higher, type 3-4 hernias, patients with esophageal dysmotility or dysphagia as chief complaint. Out of 206 primary hiatal hernia repairs, toupee was performed in 64.6% and fundopexy in 35.4%. There was no difference in gender, BMI, and dysphagia. Patients with fundopexy were older, had higher ASA, and more complex hernias. Operative time and length of stay was longer in the fundopexy group. However, perioperative complications were comparable. The need for NG tube, gastrostomy tube, and postoperative dysphagia were comparable. A questionnaire at 26.6 months in the toupee group versus 6 months in the fundopexy group showed higher patient satisfaction in the fundopexy group. At a median follow-up time of 29.7 months, versus 13.5 months, symptomatic recurrence requiring reoperation at our center was seen in 11.3% in the 2-pay group versus none in the fundopexy group. We conclude from our preliminary data that fundopexy is a simple surgical modification with better short-term outcomes compared to 2-pay fundoplication. Longer follow-up time and objective studies may alter the surgical approach to hiatal hernia repair. We acknowledge the limitations of our study as shown on this slide. Thank you.
Questions?
Excellent work. I guess I'm just curious what led to the desire to stay away from a fundoplication. You know, a lot of people will compare things to a Nissen, but as we kind of know now, Nissens are going away. 2-pays are much more common. We see a lot less side effects from a 2-pay fundoplication. The risk that you're taking with the fundopexy group is going, even though you didn't really show it in the short term, would be reflux later, because you're not really augmenting the lower esophageal sphincter with the fundopexy, and now you've made going back in and doing a fundoplication in somebody who wants to get off PPIs, or maybe the PPIs are not effective, more difficult. So just curious about what your your thoughts on avoiding a fundoplication when it's really not that bad.
So correct me if I'm wrong, Dr. Banky, but we have had that, and I mentioned that follow-up questionnaire that we've been doing, and essentially Dr. Banky has been calling up patients and asking them about those side effects. So are they still on PPI? Are they having reflux or symptoms of reflux, heartburn, regurgitation, et cetera? And so when we have longer term analysis on this, we'll look at it.
I will add to what Clarissa was saying. I'm sure you have done many of these intrathoracic stomach gastric outlet obstruction on octogenarian that they come in. You reduce the hernia, right? You close the crus, you put a mesh, you give them a peg, right? Many centers do that, and they do very well. So the story started with looking at those patients and then questioning the role of fundoplication, really what fundoplication does for us. That's number one. And then more and more we did, we say, hey, they're doing very well. They're off PPI and they're relatively doing great, actually. Now, the other question becomes, if we don't question the role of fundoplication today, after doing so many of these cases, and we see recurrence of 11.3% in our center, and up to 50% at 5 years in other center, and we continue to do the same thing, I think we should question it. Because recurrent hiatal hernia is a big problem. And when you anchor the fundus to the abdominal wall, if you can really decrease the hiatal hernia recurrence, I think is a big deal in hiatal hernia repair. When you do a fundoplication, you can't pexy the fundus, you can pexy the peripyloric area, because it's not going to reach. And when we put a peg or we pexy peripyloric, the fundus still can go up. So that's why we obtain the maximum length, and we start from right below GE junction. We anchor this entire fundus. Unfortunately, we can't do both. Yeah, we've seen recurrences in those cases as well, because the upper part of the fundus goes up, and then when they anchor it, redo case becomes much harder. The good thing with this, and I'm not saying is 100%, we are doing actually evaluating the hiatal hernia recurrence with the EGD, esophagram, and endoflip right now. We're comparing those two groups for a diagnostic study. I think the good thing about this, you don't break any bridges. You just bring it down, close the crus, and anchor it. And it's like we were created this way, not to create it to have a wrap around our esophagus.
Well, okay, thank you. For the sake of time, since we're running a little bit behind, let's go to our next session, next topic. Dr. Ariana Nassau, University of California, Irvine. And I am sorry if I mispronounced your name.
Don't worry, I'll say it again. Hi, I'm Ariana Nasa. I'm a resident at WashU presenting on some work that I did as a medical student. Okay. So induction into the Alpha Omega Alpha AOA Honor Medical Society may help propel a career in academic medicine. Research has demonstrated that underrepresented medicine students are less likely to be elected to AOA. So we sought to determine the demographic of surgical chairs in their gender, race, ethnicity, and AOA membership status in order to try to understand the potential long-term effects of AOA selection on academic promotion within the field of surgery. To do so, we sent an anonymous red cap survey to the chairs of surgery at the top 75 most reputable programs as rated on Doximity. We had 38 of 68 chairs complete the survey. About 90% were men, 92.1% white, and 97.3% non-Hispanic or Latino. Only 10% of responding chairs were female. No chairs identified as transgender, non-binary or conforming, Black, American Indian, or Native Hawaiian. Over half of respondents were AOA members elected during medical school, residency, or as faculty. Of the 34% non-AOA members, half reported they did not have a chapter at their medical school. Of the 25 AOA surgical chair respondents, only 1 self-identified as Asian, while 24 self-identified as white. None identified as Black or African American or Hispanic, Latino, or Spanish origin. In conclusion, the majority of the surgical chair respondents are white males who are members of AOA. Critical reflection and analysis of the components that lead to promotions within surgical leadership and AOA membership is warranted to further surgical diversity and academic promotion. Thank you for your time.
Very nice presentation. How did you get a hold of chairs? Which method did you use to get a hold of us?
We sent an email. So Dean Stamos, who's on this project with me, I believe had access to some sort of chair listserv because he was the former chair of our department and sent out a mass email.
I believe you missed a lot of those guys. So maybe you should redo it. I think one good way to do it is to go through the Chairs Society.
Oh, yeah.
There were the old emails.
I think that might have been what he did.
And I didn't get one of those.
I apologize.
And yeah. So you have no idea where do I belong with that list, right?
So
Sorry we missed you.
Actually, to respond to that, I actually thought that a better way to actually get that information, which might not be perfect, but better than this, is not to send out a survey. If you go to the Society of Academic Chairs and just look through that, you can get a whole lot of that information because I look at your data, none of there's several African-American chairs, but none of them respond.
Yeah.
So you analyze that data as zero.
Yeah,
So
I agree.
there are better ways, I think.
I definitely agree. At first, that was the way that I wanted to kind of go about it, was looking at it. But then I think we felt like we might miss some sort of like racial or ethnic groups that aren't exactly obvious based on just looking at someone. We wanted them to identify them on their own, but definitely agree.
All right, thank you.
Thank you.
The next presenter is Dr. Jennifer Lee from the University of California, Los Angeles. All right.
Good afternoon. Thank you for the chance to present our talk today. I have no disclosures. Liver transplant for end-stage liver disease has changed drastically over the last decade, but literature on acute liver failure remains sparse. We wanted to study the evolution of liver transplant for acute liver failure and to identify predictors of outcome. This was a retrospective cohort study over 18 years on all patients undergoing liver transplant for acute liver failure at a single center. The patients were then divided into those who were transplanted in the early era and those who were transplanted in the modern era. Multivariate analysis was then performed to identify predictors of patient survival and futility, which is defined as death within 90 days of transplant. A total of 250 patients underwent liver transplant during the study period for ALF, including adult and pediatric patients. 166 were in the early cohort and 84 were in the modern cohort. Etiologies of ALF have changed over time, with more patients being transplanted now for autoimmune hepatitis and drug-induced liver injury, fewer for cryptogenic and shock liver, while acetaminophen and viral hepatitis-induced ALF remained stable at our center. Consistent with what we have seen with our general liver transplant population, The patients in the modern cohort appear to be sicker, as indicated by their higher MELD scores, need for pre-op vasopressors, and dialysis. In comparing the two eras, there was no difference in patient and graft survival between the two cohorts. On multivariate analysis looking at outcomes within the modern cohort, pre-op mechanical ventilation was associated with futility, and pre-op seizure was predictive of worse patient survival. In summary, etiologies of acute liver failure leading to a liver transplant have changed. Patients receiving transplant in the modern cohort at our center were sicker, but patient and graft survival have not changed. Pre-op mechanical ventilation was associated with futility, and pre-op seizure was associated with worse patient survival. Thank you.
Thank you. Questions?
Hi, Chuck Rosen, Mayo Clinic in Rochester. What a wonderful series that you've presented. It's a very large experience for those that aren't familiar with the transplant numbers for acute liver failure. My question for you is, I presume that the deaths were mostly due to intracranial cranial herniation, and if so, do you use intracranial pressure monitors, which might be more predictive than ventilatory status?
We do use ICP monitoring in select patients. Usually it's at the discretion of the neurosurgical team. And in our data, which is not presented here, but the use of ICP over time has actually decreased at our center, and it wasn't associated with the outcome. But I think we have to look further into that.
I think we still have like 16 seconds. So the question I have for you is, what's the criteria you use to transplant patients with acute renal failure?
So all the patients that we identified with acute liver failure met the criteria, the ASLD criteria for acute liver failure, which is usually INR over 1.5, and then any degree of hepatic encephalopathy, and no prior cirrhosis, and also the duration of the illness has to be within 26 weeks. And so most of them at our center that were actually transplanted here already came with severe hepatic encephalopathy, and they were then discussed at the transplant selection committee and listed if there were no other contraindications.
Thank you.
The next presenter is going to be Dr. Joyce Pang from the University of New Mexico.
Good evening. I'd like to thank the Western Surgical Association for the chance to present our project. My name is Joyce Pang. I'm a general surgery resident at the University of New Mexico, and our project is entitled Medical Student Perspectives and Shelf Performance on Virtual Clerkships During the COVID-19 Pandemic. Not working.
There you go.
Oh, there we go. So briefly, I want to talk about the impact of COVID-19 specifically at our institution on undergraduate medical education. So medical students were pulled immediately out of clinical clerkships, and we actually split the curriculum into 3-week virtual clerkships in the first half of the academic year, followed by shortened in-person clerkships in the second half of the academic year. So for our research question, our study really had 2 main aims. The first one was to quantitatively compare medical student MBME shelf performance in the traditional and virtual curriculums, and the second was to qualitatively explore medical student experiences during the pandemic and with the virtual curriculum. We hypothesized that the virtual curriculum would be non-inferior to that of the traditional curriculum in delivering clinical knowledge, and that student shelf performance would be the same or better. So for our quantitative methods, we included all third-year medical students who underwent virtual clerkships and those who underwent traditional clerkships during the 2 years, the first with COVID and the second for the year prior. We excluded off-cycle students, and we compared both percent correct and percentile scores of students who had completed the traditional curriculum and the virtual curriculum. So as you can see from our quantitative results, overwhelmingly for most of the clerkships, so there were no difference in the percent correct or percentile scores, with the exception of psychiatry and OB/GYN. For our qualitative methods, we recruited focus groups from all 3rd and 4th year medical students who have participated in at least 1 virtual clerkship. We interviewed a total of 17 medical students in 3 focus groups. Focus groups, the interview guide was developed by the members of a research team, which included a medical anthropologist, a surgical attending, a surgical resident, and 2 medical students. And we coded the transcripts with 5 members of the research team as listed above. Codes were then grouped into themes, which were then reviewed and discussed by the research team. I really want to highlight the major themes that came out of those focus groups. Really, the first one was that the COVID-19 pandemic presented challenges to students' well-being in the form of increased anxiety, stress, and frustration, but also allowed more time with family and partners at home. Students struggled with isolation during the virtual curriculum and found themselves needing to modify their study habits. Students appreciated the flexibility that the virtual curriculum provided. Students did not feel that the virtual curriculum adequately prepared them for the clinical environment and were concerned about its effects on their specialty selection and residency preparation. In-person clinical experiences cannot be replicated virtually. A dedicated, flexible NBME shelf study time during clerkships could be beneficial for structuring the third-year curriculum in the future. And so truly, in conclusion, despite challenges to well-being and learning, medical students were able to adapt to the virtual curriculum. Students appreciated the flexibility that the virtual curriculum afforded, but emphasized that in-person learning is invaluable. And really, they recognize that they gain a significant amount of knowledge from in-person clerkships, and this is reflected by our quantitative data, in which we see no significant differences in shelf scores, despite increased asynchronous independent study time. And lastly, there may be a benefit in a 1 to 2 week flexible dedicated time during clerkships to focus on didactics and NBME shelf study in the future. And with that, I'll take questions.
Questions?
Erica Sutton, Morehouse School of Medicine. So there were lots of things that maybe our students were doing or not doing at home during this clerkship time. And do you know if your school uses any adjunctive tools that are commercially available, such as Amboss, Aquifer, Online MedEd? And do you have any insight into student utilization of those resources during this time?
Yes, so we actually got great data from that for our focus groups. So students heavily relied on, for example, UWorld, which is commercially available for shelf study. And one thing that they wanted to express was that they liked having kind of that downtime to really utilize some of those resources. But they also said that really what they wanted was to be in person and be really on the wards.
Great study, and thank you for both methodologies, really, in kind of answering this question. Good job.
Thank you, Dr. Sutton.
All right, thank you.
Thank you. Our next speaker is Dr. Teresa Rodriguez from the University of Rio Grande Valley.
Good afternoon. My name is Teresa Rodriguez, and I just want to thank you for allowing me to give this presentation today. I have no disclosures. So anyone that's performed a thyroidectomy knows the importance of a meticulous dissection to avoid accidental excision of the parathyroid glands. There are multiple modalities that have gone into research to identify the parathyroid glands and help preserve these. Extensive research has been performed, and one important research article that came out actually found out that the parathyroid glands have the ability to innately autofluoresce. Utilizing this information, a new device called the PTI, or parathyroid eye, was created. This helps measure the autofluorescence level under near-infrared light. This confirms visual identification of the parathyroid glands and is an intraoperative, small, handheld, pencil-like device that can scan fatty tissue for the presence of parathyroid tissue with penetration of light within a few millimeters. This helps eliminate the need for frozen section confirmation. So utilizing this information and utilizing this device, we performed a retrospective chart review that looked at 50 consecutive total thyroidectomies or completion total thyroidectomies for benign or malignant disease before the use of PTI versus with the PTI. This was performed with the use of a single center study as well as with a single endocrine surgeon. The number of parathyroids identified visually or with a PTI device were reported. And we also analyzed the PTH and calcium levels in the postoperative care unit as well as at 1 week follow-up. What we found was that on average, 1.76 parathyroid glands per patient were actually able to be identified first utilizing the PTI device. However, on average, the mean number of parathyroid glands identified with or without the PTI remained relatively the same. Also, we found that the immediate postoperative PTH levels with the PTI was found to be at 23.4, however, without the PTI was a little bit more elevated at 31.3. Postoperative calcium levels remained somewhat similar, as well as follow-up PTH and calcium levels had no statistically significant difference. We had approximately 13 versus 16 patients that had PTH level of less than 10 with and without the PTI, and we only had one patient that was found to have persistent hypoparathyroidism at 6 months, accounting for roughly 2% of our total patient population. So in conclusions, our results found that the parathyroid autofluorescence under near-infrared light enhances parathyroid gland identification. This helps eliminate the need for parathyroid frozen section confirmation. However, a reduction in postoperative hypoparathyroidism cannot be established under the use of an experienced endocrine surgeon.
Thank you.
Thank you, very nicely presented. You have one metric of just, because you have 4 chances to preserve a parathyroid and avoid hypopara. Did you look at how many parathyroids were removed within the operative specimen inadvertently?
Yes, actually we did. We measured actually intrathyroidal parathyroid glands as well as inadvertent. We found that actually wasn't really much of a difference. Further kind of research needs to be performed in this because we sometimes think we have the actual parathyroid, but before we had the PTI, we didn't send this for pathologic confirmation.
I guess the other place you get the parathyroid would be like in the level 6 lymph node fat pad if you're doing a thyroid cancer and looking to preserve it.
Yes.
Hi, Hal Trikel from MD Anderson. I enjoyed your talk. You know, the idea of parathyroid glands having autofluorescence has been around, has been demonstrated for over a decade. I remember, 10, 15 years ago, the idea of methylene blue, for instance, being used to help identify parathyroid glands, but that never really took off.
Yeah.
Why do you think that PTI, given what you're showing here, will be something that should be adopted potentially?
This is something that has actually a little bit more interesting characteristics in the fact that this methylene blue has its own sort of issues and morbidities that can be associated with it. There's certain patient populations that can't receive methylene blue, or any kind of intraoperative dyes have their own risks that are kind of carried along with that. With the PTI autofluorescence, this really has minimal variability between patients and has a lower chance of risk of any kind of adverse outcome. And near-infrared light really hasn't been shown to have that much adverse outcomes with patients. The only symptoms or any kind of issues that patients will really have if it's intraocular, like more corneal effects, but we're not obviously pointing that towards the patient eyes or to our own, so.
Richard Prince, North Shore. Is there a learning curve, and is it worth the cost?
I'm sorry, what was the first part of your question?
Is there a learning curve to this technique, and is it worth the cost?
The learning curve is minimal. We have to use just the thyroid gland. You use that to kind of get a baseline measurement. It's just with the pedal. I mean, every surgeon knows how to use a pedal intraoperatively, so if you're able to do that, you're able to use this device at the same time. Unfortunately, right now, the cost is probably the biggest driving factor. It adds about $500 per surgery for, an identification of a gland that hasn't really shown any benefit compared to, as of right now, just assumed conservation of the parathyroid gland.
All right. Well, thank you.
Thank you.
Dr. Dewey, you're up next.
Thank you to the Western Surgical Association for the opportunity to present, and thank you for all your attention. The purpose of our study was to assess the impact of a structured precision medicine program on the adoption of genomic and genetic testing within our tertiary community cancer center. I have a few disclosures in terms, but none of them really conflicts, just consulting arrangements. So we established a precision medicine team with myself as a physician leader, a PhD genomic scientist, a molecular pathologist, a physician geneticist, 3 genetic counselors, and administrative support staff. We analyzed the genomic data related clinical data over a 3-year period from 2018 to 2021. We found that the number of somatic, commercial, large gene panel tests ordered grew substantially over a 3-year period from 661 to 1,882 per year. The most common tumor sequence included lung cancers, breast cancer, ovarian cancers, but included a large variety of predominantly solid tumors. We did secondary in-house curation and annotation, which resulted in additional recommendations beyond what was presented in the commercial lab report in 43% of cases. And this could include off-label drug options, clinical trial options, or recommendations for referral to a genetic counselor. The number of patients referred to genetic counselors has continued to grow over the past really 20 years. With an increasing proportion of patients having non-breast and ovarian cancers as depicted by the orange portions of the bar. The blue is the breast ovarian. It reflects the great effort around education of both the public and providers, but we've looked at other cancers, and when patients were identified as having pathologic germline variants, they were referred into a variety of high-risk cancer screening programs. The physicians also rated the usefulness of the precision medicine program in their practice as a 6.6 on a 1 to 7 Likert scale. So we saw greater added value with greater options presented to the patient 43% of the time. Genetic counseling and germline testing was recommended in 10.3% of patients. We continue with educational efforts, including molecular findings presented at molecular tumor boards and subspecialty cancer tumor boards. We also made operational improvements, which resulted in fewer quantity non-sufficient and quality non-sufficient DNA tests, and the average turnaround tests decreased over time as well. So the use of somatic germline and somatic genomic testing is increasing. Education and decision support are highly valued by physicians, and this demonstrated patient benefit and improved physician understanding of the clinical utility is contributing to increased adoption at our center.
Thank you.
Great presentation. I applaud you for your efforts. I think this is an area that definitely requires added focus, and I applaud you for doing so. What do you think is the greatest barrier in your experience now to more widespread adoption of this technology or this effort?
Yeah, I think good outcomes data demonstrating value or clinical utility. We're seeing it. California is interesting. They just passed a law that insurance companies essentially have to pay for large panel testing now in patients with stage 3 and stage 4 cancers. In other words, insurance companies can't deny them. I don't know the full impact because it hasn't been implemented yet, but good outcomes data and also linking cost so that we know we're actually saving money and getting better outcomes. There's not a lot of that data out there yet. There's a little bit.
Thank you. The next speaker is Dr. Hop Tran Kao from the MD Anderson Cancer Center. Okay.
Yeah.
So we'll move on while he's doing that.
Go ahead.
42. I am now going to try to pronounce your name from Ascension Providence Hospital. I won't be disrespectful with your name.
I was waiting for that.
How do you pronounce it?
My name's Sujitha Nithyanandan.
Yes.
It's a very long last name.
That is easy. Do you have her slides? Okay.
So my
Make
name's
sure your mouse
Sujitha.
works. Make sure your mouse works with that. Awesome. There you go.
Disclosures, I'm an elected HSA member at my teaching institution. So residents and fellows spend several years in postgraduate medical training, which can be a challenging time as we dedicate nearly all of our resources to our training. Wellness, diversity, equality, inclusivity, as well as social and financial support significantly affect the quality of resident and fellow education. For this reason, many institutions have created house staff associations to serve as an advocate and voice for residents and fellows to discuss these factors. This study compared house staff involvement in GME in institutions with and without HSAs to determine the impact HSAs have on resident and fellow training and wellness. A questionnaire consisting of 18 questions regarding house staff involvement with GME was sent out to 700 DIOs. Institutions with less than 2 ACGME accredited programs were excluded from the study, and demographics and outcome data were compared using standard statistical methodology. 108 DIOs responded to the survey. 78 institutions had HSAs and 30 did not. 70 were community hospitals versus 38 university hospitals. On average, there were 300 house staff members at an institution, ranging anywhere between 15 to just under 1,500 house staff members. Our study results showed that 76% of institutions with HSAs discussed issues related to duty hours compared to only 3% of institutions without. 31% of institutions with HSAs discussed issues regarding educational allowances for books and devices compared to only 3% without. 60% of institutions with HSAs provided career planning support to house staff compared to 27% of institutions without HSAs. 53% provided support with legal support compared to 34% without HSAs. And 21% of institutions with HSAs discussed issues regarding childcare versus only 6% of institutions without HSAs. And 19% of institutions with house staff associations discussed issues regarding arranging housing and hotel accommodations during the COVID-19 pandemic, opposed to only 3% without HSAs. So in conclusion, postgraduate medical training institutions with HSAs were noted to have significantly more resident and fellow involvement with GME, discussing issues regarding wellness, diversity, equality, inclusivity, social and financial support than institutions without HSAs. HSAs provide residents and fellows a platform to discuss and improve their learning environment, and based on these findings, further research needs to be conducted regarding the impact HSAs have on resident and fellow training and wellness.
So I actually would have expected your response rates to be exactly opposite, more academic centers and community community programs responding. What was the population that didn't respond? Was that majority academic programs, or why are more community programs having the HSAs compared to academic?
So we actually weren't able to collect that data in terms of which institutions did not respond in terms of community versus university programs. We found that actually the community programs that did have HSAs were actually larger centers versus the smaller centers, though.
Very nice job. What I suggest you do next one, you presented here next year, is ask the residents what do they think about DIOs. The DIOs did a great job. 76% of them responded. I guess they're not really that busy. Because I never heard that 76% of people who get surveyed respond. So that's great. Maybe they're really interested in doing this. But why don't you ask the students, the residents, what they really think, how these issues are related and how they are addressed.
Yeah, that's a very good point. Thank you.
Should make me co-author, right?
Thank you very much. All right, moving backwards. MD Anderson, Dr. Cow.
Okay, good afternoon, good evening. Thank you for the opportunity to share the early results from a quality initiative at MD Anderson. I have no disclosures. So gaps in patient perception versus reality of their cancer situation are well documented. which may have wide-ranging implications and can add cost and pain and suffering to the patient and their families. And so as part of a Mind the Gap initiative that was rolled out across the institution to try to narrow that gap through early and frequent discussion of goals of care and advanced care planning, our Division of Surgery implemented a rule that advanced care planning should be documented for every patient before their procedure in order to achieve goal-concordant care. To facilitate the adoption and implementation of this practice, we instituted several steps, including developing smart phrases, educational material, having town halls, going across the different departments to faculty meeting and APP and fellow meetings, and then making it part of the incentivized process at MD Anderson, as well as transparency and reporting. And with that, these efforts, we started at about 6% of patients a year ago before implementation and rollout, having a preoperative advanced care planning note all the way now to 53% across 20,000 cases, just thereabouts. And we had originally set out to have a goal or reach a goal of 30% for the entire month of August. And you can see that we were at 53% with a cumulative rate of 34% for FY21, which is well ahead of our expectations. So the next steps will be to assess the quality of the ACP process, also the impact it has on patients and their families, and also perhaps refining the surgical informed consent process to better align with goals of care. Rather than just talk about the technical and perioperative outcomes, should we also think more broadly about oncologic benefits versus quality of life costs? So thank you very much for your attention, and I appreciate that.
Thank you very much for that great presentation. I have been amazed over my career, which included working at the Huntsman Cancer Institute in the ICU, at the lack of medical oncologists and radiation oncologists of even telling any kind of truth to the patient. And, you know, the number of times I had to talk to patients and their families that, you know, had leukemia or, you know, something, and they were on their, you know, desk doorstep, and just have that goals of care conversation. I was like, what are we doing here? So I'm wondering if you have the medical oncologists on board with this. I mean, at MD Anderson, there's a lot of them. You train a lot of them, because this is a huge gap, in my opinion.
No, you're 100% correct, and they are definitely involved in this. It's an institution-wide cross-departmental effort and cross-divisional effort. That situation happens all the time. Phase 1, right, clinical trials, patients, they are terminal. And you can see from the survey that I showed, more than 50% of patients who were treated with palliative intent thought that the goal of care was curative. And that was a study that came out of MD Anderson. So that's a huge push behind this study, behind this initiative.
So if your division's at 30%, what are the medical oncologists?
Yeah, so the goal for them is a little different. It's not preoperative ACP. It's having an advanced care planning note in the chart by the 3rd clinic visit. That's their goal. And where it helps a lot is to not only establish goals of care for the patients, but also facilitate providers understanding what the goal is. So if the patient comes into the, to the emergency room or to the ICU, people know they're not being treated with curative intent, so maybe they shouldn't even come into the ICU. Maybe they shouldn't have these invasive procedures done, when really they're being treated with palliative intent at the end of life.
Since this is a really important topic, I just want to ask, so during tumor board, this would be actually a perfect place to have part of that conversation, because, the medical oncologist might have a different conversation with the patient and the surgeon.
Yeah, no, you hit the nail on the head. I mean, quite often nowadays at tumor boards, when they present cases where patients progressing through 2nd line, through 3rd line therapy, and they're considering some local, directed therapy, oftentimes it is incumbent upon us surgeons, and this is a plug I'm making here, to kind of remind our colleagues that, hey, sometimes we're just out of options, right? And we're facing a situation that is not salvageable, and we need to switch to, palliative and comfort care and hospice care rather than pushing on.
All right, thank you.
Thank you.
Our next speaker is Dr. Aprem Jihad from Ascension Province Hospital.
Good evening, everyone. I'm Dr. Apram Jod, and I'll be presenting our work on natural history of DVT and PE in COVID-19 patients. No disclosures. Severe acute respiratory syndrome coronavirus, or SARS-CoV-2, is the novel coronavirus first detected in Wuhan, China, that causes COVID-19. Significant inflammation drives the COVID-19 related SARS, and the postulation that the respiratory failure may result from inflammatory-derived hypercoagulability from in situ thrombosis or embolization in the pulmonary vasculature. By systematically screening the COVID-positive patients during their stay, we attempted to define the natural history of DVT and PE in this particular population. For our methods, from April 1st, 2020 to July 1st, 2020, we looked at all the critically ill COVID-positive patients in our ICUs. They were prospectively imaged twice weekly by duplex ultrasounds with focus on thigh-level fem veins, pop veins, and tibial veins for the duration of the admission. Suspected DVTs on these preliminary ultrasounds were then confirmed by formal imaging. Correlation with multiple secondary variables was then evaluated. For our results, 44 patients were scanned and were found to have DVTs in 10. 6 were popliteal and femoral, 4 were infrageniculate, and we had no PEs in our study population. The severity of illness was found to be varied greatly among the individual patients. In terms of correlation of DVT with patient factors, we looked at about 20 patient factors, and these factors noted here were found significant on univariate analysis, and on multivariate, immobility and prior history of thrombosis were found to be significant. In conclusion, the incidence of clinically significant DVTs was only 13%, which falls within the regular range of 10 to 18% DVTs in the medical surgical ICU patients. Our data also suggests that the local inflammatory injury to lung is more likely to cause respiratory failure than embolization from DVT. Thank you for giving me the chance to present our work. I'll take any questions that you guys have.
So Lee Newmeyer from Jacksonville. I'm just curious about that. And actually, as I'm thinking back of all our COVID patients, it was really more of an issue not with DVTs and PEs, but they would frequently stroke. We had a lot of that. Did you look at that in your data at all?
We did have some patients who did undergo some ischemic and hemorrhagic strokes, but nothing of significance that came out of it.
Okay, thank you. Our next speaker will be Dr. Megan Lewis from, I think it's LA County and USC Medical Center.
Good afternoon. I'd like to thank the program committee for the opportunity to present. Severe hepatic injury is associated with significant morbidity and mortality. Non-operative management of blunt hepatic injury has long been associated with improved outcomes. Non-operative management of gunshot wound to the liver has also recently been associated with improved outcomes. This is the first study to compare management and outcomes of patients with severe liver injury due to gunshot wound versus blunt force mechanism. A retrospective single-center analysis of all patients with grade 3, 4, or 5 liver injuries due to gunshot wound or blunt mechanism was performed over a 5-year period. Clinical characteristics, injury severity, management, and outcomes were evaluated. Primary outcomes were liver-related complications, and secondary outcomes included mortality, length of stay, and ventilator days. A multivariate analysis was used to determine risk factors for outcomes. Overall, liver-related complications occurred in 40.7% of patients in the gunshot wound group compared to 27.4% in the blunt group, and this was significant. In addition, necrosis abscess and bile leak biloma were significantly increased in the gunshot wound group. A sub-analysis was performed of patients with grade 3 injury. This also showed increased necrosis abscess and bile leak myeloma in the gunshot wound group. Another sub-analysis was performed of patients with isolated liver injury. This demonstrated increased overall liver-related complications, including increased necrosis abscess and increased bile leak myeloma in the gunshot wound group, as well as increased hospital length of stay, ICU length of stay, and ventilator days in the gunshot wound group. On multivariate analysis, gunshot wound mechanism was identified as an independent predictor of mortality. In conclusion, in severe hepatic injury, gunshot wound is associated with a higher incidence of liver-related complications, increased hospital and ICU length of stay and ventilator days, and is an independent risk factor for mortality. Thank you.
Questions, except from Dr. Latifi.
I'm happy to get up and talk.
I was going to ask too, go ahead.
Welcome, Megan. Dr. Lewis was a resident I helped train not so long ago. Anyway, I remember seeing when the initial data was presented from your group about, and we were all shocked about treating gunshot wounds non-operatively. So my question to you now is, are you changing what you're doing because of those increased risk with a gunshot wound to the liver, right? They have more complications. So are you going to operate on them now or no?
So it's actually the opposite. So what we've shown is that they have more complications when they're operated on instead of
when they're operated
non-operative.
on.
And so,
Pay attention.
and that's one of the reasons why we have to do the multivariate analysis, is because more patients in the gunshot wound group, as you've observed, have operations, a much higher percentage. And so when we do the multivariate analysis, we control for operative versus non-operative management. And even then, even with similar grade injury and similar management, patients in the gunshot wound group have a higher mortality. So we really have to sort of, I think going forward, especially at our center where we frequently manage gunshot wounds non-operatively, find a way to prospectively match patients and figure out with same mechanism, same management, how...
Which are the ones that you should operate on?
Could that be perhaps your initial grade injury, but the blast effect's the bigger issue?
I think so. I think that that's certainly a component. I think what comes to mind for me is that obviously with a blunt mechanism injury, there's certain fixation points of the liver, and the injury is going to be determined by those fixation points, as opposed to with a gunshot wound, the trajectory of the missile is entirely based on the operator. And
right.
So.
All right, thank you. Our next presenter is Dr. Brooks Lowry from Louisiana State University Health Science Center in Shreveport.
Good evening, and thank you for allowing me to present. My name is Brooks Lowry. I'm a surgery resident at LSU Shreveport. This project is looking at wound complications from patients with reduction mammoplasty and also a novel pectoral block technique. So a little background, many plastic and reproductive surgeons will consider increased BMI to be a relative contraindication to reduction mammoplasty because of increased post-op complications and also patient dissatisfaction. But we also know patients with higher BMI are more likely to have symptoms from macromastia. And some studies have even shown acceptable or comparable outcomes in obese patients, showing no difference when controlled for BMI. So we have 2 plastic surgeons at our institution that performed reduction mammoplasty without limiting the availability due to patient BMI, and they also performed a pectoral block randomly for pain control. And one of the surgeons hypothesized that the outcomes were improved in the blocked patients, and they asked us to study it. So our questions are, is there a difference in outcomes between the obese patients and the non-obese, and also did the pectoral block actually influence their outcomes? The patients were identified from years 2015 to 2019 with a single CPT code. This was a retrospective review. There's 453 total patients included in the study, and 80 of these received a pectoral block in the perioperative period. They all had pre-op evaluation and post-op follow-up in the surgery clinic. The outcomes we tracked are shown here: delayed wound healing or dehiscence of wounds, fat necrosis, hematoma, seroma, hypertrophic scar or keloids, surgical site infection, nipple loss, and breast asymmetry. So the first results we have, we divided all the reduction mammoplasty patients into two groups to simplify the analysis: BMI 20 to 35 and BMI 35 plus. We looked at the incidence in each one and compared delayed wound healing, fat necrosis, all of those outcomes. We found that there was a significant difference between the lower BMI and high BMI group in delayed wound healing and asymmetry. The other ones, there was no difference. And next, we looked at the influence of the pectoral block. We calculated the incidence of each of those outcomes for the blocked patients and the unblocked patients and compared those similarly to the other slide with chi-squared test. We found the incidence of delayed wound healing in the obese patients was significantly reduced with the pectoral block. So 27% of the delayed wound healing, 27% of patients in the high BMI group had delayed wound healing without the block, but then only 10% of those patients had delayed wound healing that got a pectoral block. And this chart just shows that this is the only significant p-value. So in conclusion, in our cohort, delayed wound healing and asymmetry occurred significantly more frequently in the morbidly obese patients following reduction, in keeping with the previous studies. But also, reduction mammoplasty can be performed in morbidly obese patients with acceptable and generally comparable outcomes to non-obese, as the other outcomes were essentially were not significant. And also, the use of the pectoral nerve block with a long-acting local anesthetic was associated with decreased wound complications in the higher BMI patients, but did not increase the other outcomes. Thank you. Thanks.
University of Arizona.
Oh. All right, so thank you, WSA, for giving me this opportunity to present some of our research work. We have nothing to disclose. We already know that the incidence of colorectal cancer in the last 30 years is trending down, but we see a significant increase in young patients. So the aim of this talk is actually to look at some clinical pathologic characteristics that you see and compare between older patients and younger patients. So this is NCDB database analysis over 14 years from 2004 to 17. We included all the patients that had colorectal cancer and underwent surgical intervention. We used the ICD-10 diagnostic code to actually identify these patients, and that was a statistical analysis. But more importantly, our outcomes was look at some of these characteristics that differentiates early onset colorectal cancer and late onset. We also looked at 30-day readmission and 30-day mortality, and also a little longer term mortality, which was 90 days. In terms of our results, we saw that blacks and Hispanics have a higher incidence of early onset colorectal cancer compared to late onset. In addition, we saw a significant higher rate of rectal cancer in younger patients than in older patients, and less colon cancer. The patients with young early onset colorectal cancer had a more poorly differentiated tumor biology and presented with a higher stage disease, like in stage 3 and 4. Because of that, you see that they tend to have more radiation therapy, immunotherapy, and also chemotherapy compared to older patients, which makes sense because a lot of them were rectal cancer and tend to actually have more surgery. So the 30-day readmission rate was a little bit higher for early onset cancer, but mortality was low, and 90 days, both in 30 days and 90 days compared to older patients, again, clearly due to the fact that younger patients with more physiological reserve. So in conclusion, there's actually racial as economic and ethnic disparities, but early onset colorectal cancer tend to have more aggressive tumors and tend to use more adjunctive therapy along with surgery. And despite having aggressive disease, these patients tend to have a better survival, clearly due to their physiological reserve. And thank you. Take any questions.
I'll ask the first question. You know, when you look at, you've looked at a very wide time frame in NCDB, and when you look at racial, ethnic, and socioeconomic disparities, 2010 is a real marker with, you know, Medicaid expansion and whatnot.
That is actually very true. And so that analysis was actually split into two. In the manuscript that we're writing, we're actually doing analysis before that to look at, especially for the racial component. That's absolutely true.
Interesting. It's notable, Mike Demers, sorry, Newport Beach. It's notable that guidelines have just been reduced to lower the age for colonoscopy screening. But I wonder, in particular, in the young group, were you able to get any data regarding like Lynch syndrome or other things like that might predispose you, genetic syndromes like Lynch that might predispose you to colon cancer in a younger person?
Interestingly, most of this analysis that we've actually done, we've done them on sporadic colorectal cancer patients. So again, you probably notice 80% or more of patients who develop colorectal cancer, it's sporadic. There's no genetic predisposition to this patient. But there might actually be genetic predispositions that we just haven't found yet. That's why I was interested in your talk, looking at these gene panels, which we actually have done in the past and noted some genes that are overexpressed in these younger patients. So in a previous study that we did in 2011, we actually advocated for the screening age for colorectal cancer to actually go down, because we saw a lot of patients between age 32 to 40 that actually had a significant increase, especially in rectal cancer. So if you think about this, by the time now the screening age has recommended to go down to 45, so that might still even be late. So because again, that is the window where you actually see a significant uptake in increase in incidence. So genomics are important at screening, and if we actually come up with more non-invasive diagnostic tools, especially for younger patients, I think we would be able to capture this at an earlier stage.
Okay, thank you.
All right.
So that concludes the session. I think the next thing is the president's reception and dinner. And I think it's 7:30 in the Olive Grove. Not Olive Garden. That was a long session.
I know.
There was nobody that made 2 minutes. Do I need to click this video?
Ask Lee. Lee.
Hey, Lee. I don't see Jill. Do I bring it? Okay.